So first off, we're going to verify that our order is in, and then we're going to gather our supplies. Once we've gathered our supplies and going in the room, we're going to verify our patient with 2 patient identifiers, wash our hands, don gloves. Also going to bring a friend in the room. Another tip is to let your unit clerk know, so that way they know where you are as well. Supplies that we're going to grab, I'm going to grab pressure tape. So I went ahead and cut 3 pieces just for my wedge pressure dressing after I'm done with pulling the sheath. I have gauze, I've got skin prep, pressure tape, atropine, I've got chuck pad, and biohazard bag. Also going to, while we verify our order, we're going to verify our ACT. Our ACT is going to, we want our ACT to be less than 150. So a good rule of thumb is the 150-150 rule. So ACT lower than 150 and a systolic blood pressure lower than 150. So if our systolic, while we're assessing our vital signs, is above 150, we want to make sure that we get a PRN to lower that blood pressure, because the longer we wait, the ACT is going to drop lower, and then you have risk of clot formation on the sheath. So now we're going to explain the procedure to Freddie. So Freddie, we're going to remove this big arterial IV out of your groin. We're going to have to hold a lot of pressure to make sure that we're achieving hemostasis here so that we don't bleed out. We also have medication in the room along with a friend, just to make sure that if your blood pressure does drop along with your heart rate, that we can handle it. So after explaining the procedure to Mr. Freddie here, I'm going to have my friend mark the distal pulses, assess baseline vital signs. Like I talked about, we want to make sure our systolic is below 150. The higher the pressure, the harder the pull. We're also going to confirm a patent IV along with fluids hanging, and we have atropine in the room. So next, we're going to position the bed flat, just like so. We're also going to make it at a comfortable height for the person holding pressure. So me, it's at a comfortable height for me. We're going to make sure that our call light is within reach. If we don't have a friend in the room, we're going to put our gloves on, which I already have. We're going to remove our sheet here. Then that's when we're going to put our chuck pad down. I like to put my chuck pad up above the patient, so that way it kind of provides me like a tray, just so I can get rid of everything at the end. So after chuck pad is down, we're going to remove our dressing. We're going to check our site, make sure there's no bleeding, hematomas, anything like that we're noticing. We're going to take these 2 fingers here. We're going to locate our femoral pulse above the insertion site. So if you think about it, the angle of the needle that goes in is not going to be the insertion point on the skin. The actual puncture point is going to be further down. So that's why we're holding pressure up here. So once we located that femoral pulse 1 to 2 centimeters above the insertion site, we're going to take and hold firm pressure with this hand. We're going to remove the sheath with this hand. We're going to have the patient exhale and hold it, just to help with that vasovagal response. So while we're removing this here, slowly have them exhale and hold it, and then there we go. We're going to start holding pressure, just firm enough so we're not occluding distal flow, but just enough so we're stopping the bleed. So we're going to hold pressure here for anywhere to 15-45 minutes, just depending on sheath size, anticoagulation status. So this was a diagnostic procedure, so we'll probably be here for about 15 minutes or so. So if Freddie had started to yawn while we're holding pressure, that's when our friend is going to give the atropine and run our fluids at 999. A yawn is an immediate sign of a vasovagal response, but since we didn't have to do that, we're just going to keep holding firm pressure. While we're doing this, our vital signs are going every 3 to 5 minutes. Our friend is assessing our distal pulses, also documenting. So once we have achieved hemostasis and that time has come up, we're going to lift. We're going to pull a gauze here, kind of clean the site so that we get a good visualization. We're going to palpate around here just to make sure that there is no hematoma formation or any excess bleeding. Looks pretty good to me. So what we're going to do, we're going to apply our skin prep to make sure it's nice and sticky. So our tegadermal stick, we're going to take a gauze like so. Take our tegaderm. Like I said, the chuck pad makes a great trash can. Gonna apply it like so, just over top. And then, after this is on, we're gonna put our wedge pressure dressing on. So that's when this will go on like so, and then we're going to make an X with our pressure tape like there, and then we're also going to have one here, and then my third one is going to come around kind of like a smiley face. It doesn't stick to this, unfortunately, but so X here, X there, and then a smiley face to just kind of hunker it in. So after we've done that, we can raise our patient up to 30 degrees, but we want to make sure we don't go any higher just so we don't disrupt the hemostasis. We want to make sure that we're following our post-op orders. Bed rest usually for about 4 hours. To make sure that we do our neurovascular checks. So checking your site every 15 minutes for the first hour, 30 for an hour, and then every 4 hour, or an hour for 4 hours, and every 4 hours after that. And just the biggest thing is you just want to make sure that the patient notifies you if they're feeling any wetness here around the site, if they're feeling faint. You want to make sure you're making sure that we still have distal flow. But other than that, that is arterial sheath removal in a nutshell.